Hi, welcome to another episode for The Love of You. We're so excited to have you join us, and also Amy Goldman from Madonna Rehab Hospital. She's a stroke program manager and has had 17 years of physical therapist training in just neurological rehabilitation, primarily stroke rehabilitation. And Amy also serves as a chair for Nebraska Stroke Advisory Council Rehab Task Force. And so, Amy, thank you for joining us.
Sure, it's great to be here.
Today we're going to talk a little bit about rehab and what everything is happens after a stroke and things like that. And so, like I said, Amy, thank you so much for joining. Let's start by having you tell us a little bit more about what is stroke rehab and what does recovery look like after having a stroke.
Great question. Stroke rehabilitation really starts within a couple days of the patient being stabilized after their stroke in the hospital. So thanks to the good folks like at UNMC and other acute care facilities in the area, once the patient receives often the life-saving treatment that they get called TPA, for instance, if they qualify and they survive the stroke, rehabilitation really starts within a couple days of that. Even in the acute care hospital, where patients start to begin to sit up, they might begin to take a short walk to the bathroom, they might begin range of motion type activities in acute care, all the while evaluating the patient as to whether or not they would benefit and be qualified for what we call inpatient rehabilitation in an acute rehab facility or setting within a hospital. And the criteria for that is essentially a patient needs to be able to tolerate up to 3 hours of therapy a day, 5 days a week. The research has really showed us, as of the last 5 to 10 years, that more typically is better, to keep it in easy terms to understand. But the intensity needs to be at a high enough level and frequency of therapy, again, 3 hours a day, 5 days a week, to be able to get the benefits of brain recovery, what we call motor recovery for the patient's muscles, their arms and legs, to get them working again, to get a patient speaking, thinking, walking, and talking again. And so rehabilitation, honestly, is a comprehensive approach that requires a multidisciplinary team. So patients, after they leave the hospital, if they qualify for acute rehab, will be seen by a physician called a physiatrist who specializes in physical medicine and rehabilitation. They lead that team of then physical therapy, occupational therapy, speech therapy. There's a social worker, a case manager involved, nutrition therapy, recreation therapy, as well as spiritual care in some instances.
Wow.
So it's a real large team when a patient would attend an inpatient rehab program. But again, not all patients may or may not need that type of intensity or qualify for it. So there's all types of other levels of care that a stroke patient may be eligible for in addition to that, including therapy in what we call the skilled nursing facility. Patients that maybe can't tolerate 3 hours of therapy a day and maybe don't have the complex medical needs, such as the need to still monitor their blood pressure. They might have swallowing issues and they're at risk for pneumonia. They may have bowel and bladder issues. We call that incontinence. And those need to be very closely monitored in addition to any other types of medical complications. So often sending them to a skilled nursing facility, if they don't have those issues, may be of benefit and they can't tolerate the 3 hours of therapy. In addition, patients that have maybe minor deficits from their stroke right off the bat might not need inpatient rehab, and those patients often do go home, maybe with home health, or they go to an outpatient program in the area.
Okay, great. Yeah, that's a lot of great information. Where does stroke rehabilitation take place?
Great question. That, again, it depends on the needs of the patient, but there are different levels of care for stroke rehabilitation, much like there's different levels of care in acute care based on the patient's needs. For, again, the patient that really does benefit and would qualify, the best for patients right after stroke is to go to what we call an inpatient rehab program or acute rehabilitation for that intensity and frequency of treatment early on after the stroke. We know from research that The more therapy a patient gets at a high intense level that's very focused on tasks that involve their daily living skills, their mobility, their thinking, and their speech, they tend to do better. For those patients, though, that maybe don't qualify for that level of care, there's another level of care called a skilled nursing facility, as I mentioned before, and those take place in kind of like a nursing home setting.
Okay.
But it's not long-term care. That's where people can get a little bit confused. Skilled nursing means the patient still requires or needs therapy every day or every other day, and they have daily nursing needs typically. But again, their medical condition is such that they're fairly stable. They don't have high risk for complications. If that's the case, they need to be in a more of a hospital acute rehab setting. In the city of Omaha, just so people maybe who don't know, there are 3 acute rehab programs.
Okay.
Those take place at Emmanuel Medical Center, where it's inside of a hospital, as you know, with Emmanuel through CHI. They have a unit that is for rehabilitation within their hospital. The same is, it's the same way at Methodist on Dodge Street. They have an acute rehab floor, several beds to their acute rehab unit, and they focus on the same things that any other acute rehab program would. The different program in the community is Madonna Rehab Hospital, where that is a freestanding rehabilitation center that the only thing really that Madonna does is rehab. They're not linked to an acute care health system like Methodist and Emmanuel. No difference really in the type or quality of care. It's just a different type of setting.
Okay.
Inpatient rehab can either be freestanding or inside of a hospital. When you asked about levels of care, the other level of care, as I mentioned prior, was a patient maybe would go home with home health care, and those patients typically don't require the intense physical rehabilitation that you would in acute rehab. So they may be going home and only get home health care 2 to 3 times a week.
Okay.
It's still very beneficial. The nice thing about home health is it's in their functional setting, meaning in their home. So they get to practice things in their home-like environment, involving their family or other caregivers in the therapies. The final type of level of care would be outpatient, where there are different types of outpatient programs. Typically, traditional outpatient, a patient may come in 2 to 3 times a week to an outpatient setting, such as Madonna or Emmanuel or Methodist. There's a whole host of other outpatient clinics in the city of Omaha, but not all specialize in treating stroke patients. So that's the key. You typically maybe wouldn't choose a place that just does orthopedics and sports medicine. We tell our patients, while there's nothing against those clinics, they don't typically take patients that have had a neurological injury like a stroke. So you want to be able to really make sure you look for programs that treat brain injury, stroke, spinal cord injury, and other types of neurological conditions. So you know that the staff there have the expertise to treat that condition.
Sure. Yeah, that's great. What do families look for in that quality program? So like you said, looking for actual neurological expertise, that's great information. What else do they look for?
You want to look for things like, does the staff there have the training and expertise, as you mentioned, but also is it a team-based approach? There's a lot of research out there in the stroke rehabilitation research area where a multidisciplinary team-based approach can lead to better outcomes. It's a more coordinated approach to the patient's care, and it's holistic, meaning we're not just looking at the physical deficits, we're looking at cognitive, emotional, social, spiritual, occupational. So what did they do prior to their stroke, and what do they want to get back to living and back to doing their life roles? Those types of programs that are going to be way more comprehensive is what you want to look for. And in addition to that, there's a lot of new specialized services and technologies that are new to the stroke rehab world, and many programs maybe don't offer those, either from the standpoint of they are very costly. So it's typically more of your inpatient rehab programs and more comprehensive outpatient centers that offer that sort of specialized technology. And those pieces of technology can really help us in that we're not getting as long to be able to keep patients in the hospital for stroke, for rehab. So this technology can help give us a jump start with those patients and help the therapies be more efficient and not to take the place of the skilled clinician. That's not our goal. It's like an adjunct, so it's in addition to their traditional therapies. And it can help with the intensity of therapy that we're after because they get more repetitions. For instance, not to jump ahead, I know one of the questions is about technology, I presume. That technology really has the ability to allow patients to do hundreds to thousands of repetitions of a skill, which we know from, again, the literature is what it takes to relearn a motor skill. Many people don't realize, but it's not just, oh, let's walk up and down the gym a couple times in the hospital and we're going to get our walking pattern better. No, it's going to take thousands and thousands of steps with assistance of a therapist or this technology, for instance. One piece of technology that I can think of is where we harness someone up on a treadmill, we support a portion of their body weight, and they can either walk with robotic legs attached to their legs over a treadmill, or with the hands of the therapist assisting their limbs through the walking pattern. Again, it would take a therapist a lot of time to do that and a lot of extra exertion or strength. We actually set our clinicians up for injuries sometimes when we assist patients that need maximal to dependent assistance. Therefore, this technology allows us to get patients up and moving sooner in their recovery. Many patients that can hardly move themselves at all, we can be helping them move through the use of this technology. And they're getting the same benefit as maybe a patient that doesn't require quite as much assistance and doesn't really need the technology. So it's all dependent on the patient's needs. They have to meet criteria, of course, to utilize it for safety. But the world of stroke rehab is really changing amongst, as the acute care world is as well. But there's so many new devices and new technologies coming out every year. It's often getting a little tough to keep up with all of it, but it's exciting.
Yes. So as you talk about that device there, what would be I get for the purpose of helping that patient walk, but if they're unable to walk at all and you're putting them in that device, what are kind of the outcomes of those patients? Do they end up at least getting, up into a wheelchair or things like that?
Yes, patients typically that utilize these sorts of technologies and devices end up standing and walking sooner. So it might just be helping them transfer, sit to stand, in and out of a wheelchair or on and off their bed or in the bathroom, on and off the toilet. There's carryover to other activities besides walking. So the purposes or the clinical reasons we choose to use these pieces of technology are not often just for things like the walking, in this case, over the treadmill. There's even the cardiovascular benefit. We know that our patients that come to us in rehab are very, very deconditioned. After a stroke, it takes a real toll on your body, as I've heard you talk in other episodes you've had, where the physical and the cardiovascular impairments that often endure require the patient to need a lot of exercise and aerobic conditioning. So that treadmill walking really helps get the heart rate up, the blood pressure up, the blood flowing, and we can help not only with their endurance, but things like standing, transferring, walking. It also assists with their balance because many times after a stroke, you feel unsteady. That may be due to the weakness in your legs, but it also can be due to the central part of your brain that controls balance. So having them learn to walk in a supported setting and balance themselves helps carry over to when they're outside of the machine. That's the key. We never want the technologies to replace the good old-fashioned therapy. In fact, research would show you maybe don't even need all those technologies to get similar outcomes because there's many programs in the area that don't have the technologies. That doesn't mean it's a bad program. It just means that maybe they're not able to get patients up quite as soon as other facilities that have that technology. And we never want to replace the traditional therapy approach where we're working one-on-one with a therapist, we're engaging the patient and family in the rehab process, we're teaching families and caregivers to help take over skills that maybe the patient's not able to do by the time they leave rehab. Because what people still don't quite understand is when I started 17 years ago, we were able to keep a patient in rehab for 3 to 6 months. That does not happen anymore. We're talking the same type of impaired patient that we have to get out the door and home in 3 weeks or less.
Wow.
So I really want the audience to understand that too, in that it is really important where you choose to go after acute care, because the focus and intensity and quality of that program in the first 3 to 4 weeks of your recovery is critical to your long-term outcome. And that's what I tell families, all the time when they're deciding upon a program, where to go. And part of my job is to educate the patients that are referred to us or referred generally in the public. It's important when I go out and do speaking engagements that I help people understand that that first month is critical. We also used to say that, in 6 to 12 months, you're going to reach your plateau, and that's it for your recovery. Again, I'd like the audience to know and be happy to know today and excited to know that we're seeing recovery beyond 2, 3, 4, 5 years after the stroke.
Exciting.
So we never want to give up on patients, but what we do know is that first 1 to 2 to 3 months is the key time to have that intense, comprehensive programming in order to have a better long-term outcome. We do know that from the research.
Yeah. Can you tell the audience about different improvements that the stroke survivors can expect from stroke rehab?
Sure. Well, pretty much it's all your basic daily functioning areas. We address speech and swallowing. Patients can improve in their thinking ability, their problem solving and memory, and even their judgment. Oftentimes after stroke, it's hard for them to remember things or to make good decisions. And so the speech therapy and the occupational and cognitive therapy really focuses on those areas. The big one everybody always thinks about is, well, they're weak now and they can't walk. So typically when you ask a patient, what's your goal after therapy, even to the occupational therapist who gets a little cranky, they say, I want to walk again. Not maybe something to do with occupational therapy, but that's really because that's the big thing that drives them. They want to be able to get up and move and get back to their life. So I would say that some of the big things we see as far as functional improvements are mobility, improving their ability to do self-cares, which is things like dressing, grooming, and bathing, and even doing homemaking tasks like in the kitchen. Obviously the walking and the transfers, as I mentioned. And then in addition, we also want to assess their emotional recovery. How are they doing from an emotional standpoint with coping and adjusting to what's happened to them? Stroke, as I've heard you mention, which has been great in some of your other episodes, it's a life-changing diagnosis. And really up to 40% of patients will still have some sort of deficit, regardless of what rehab program they attend after stroke. So it's very, very important that they understand there may be minimal deficits, but what we teach patients is we try to give them hope in that there's ways they can overcome those by maybe doing tasks in a different way. We call that sometimes their new normal. So they may not be able to do it exactly as they did prior, but they're still independent in doing so, either with a device or a new technique or with the help of a caregiver. So that is some things that I feel are very positive outcomes of a stroke program. In addition to, I don't want to forget to talk about the issue of getting back to what's important in their life. So we feel a good outcome is if a patient can return to work. So even if it's part-time or full-time, it's important that patients get to give back to their community and back to their work environment. The kids that often have a stroke, we want them to get back to school and or college, whatever level of education they're at. That brings me to that stroke can happen at any age. So we're always advocating for the public to understand those warning signs and symptoms that, again, I've heard you guys really spell out and really emphasize in previous talks. That goes for all age groups, and I can't say that enough. I do take that with me whenever I present. I try to remind folks of being able to recognize a stroke as the first thing, because the sooner we can get treatment, the less severe some of those outcomes, those deficits are that I speak of in rehab. So we can hopefully ward off some of the devastating effects if we can get help sooner.
Great. I heard you say like different devices and just Real quick, like even, can you give us an example? I know there's different utensils you can use for eating, or how to train your left hand versus your right hand if you're weak on your right hand. Could you just touch on that maybe to give the audience just some kind of idea of different devices?
Sure. We have all types of like adaptive equipment, we call it, for like eating or dressing and bathing. The utensils that often can be weighted down if they have trouble with their ability to bring their, let's say their movements are a little bit impaired and uncontrolled. We call that ataxia. They're uncoordinated. They may need a utensil that requires a little bit of weight to help keep their arms steady as they bring the fork or spoon to their mouth. We have adaptive techniques where we can actually attach the utensil with a strap to their affected hand, so we can force that arm and hand to be working. What we don't want to do is ignore the use of that arm. We want them to constantly focus on it, look at it, try to move it in all of their therapies and in their daily activities. But there are times where they need adaptive equipment, like even, let's say, a sock aid that's going to help them get their TED hose on or their stockings on, and they only have one good arm to use to do that. Or a reacher, where they can reach things off the floor without losing their balance towards the floor out of their wheelchair, or they're unable to reach too far because of their balance. In addition, there's of course walking aids and transferring aids where they might need a walker or a cane or a type of device that way to keep them steady when they're up and moving about.
Perfect. Thank you for sharing that. Is there anything you would like the audience to know before we end the episode? Some kind of last words as we go on. I know we kind of talked about the recovery and different rehab levels.
Sure. I might just emphasize again the importance of making sure that you choose the right type and intensity of program after you've been in acute care, and understand too that, what I didn't touch on yet, not all insurance companies will cover acute rehabilitation. I get that question a lot. Typically Medicare does cover that, but it all depends on your initial functional status, your diagnosis, and any comorbidities you have, like high blood pressure, or you have pneumonia, you have a history of other things to do with your medical condition other than the stroke. So it's not a for sure thing that you would be accepted to an inpatient rehab program, but it's worth being looked into for it, and to check with your insurance, which will happen at the hospital level. The social worker or case manager would help authorize that and decide if the insurance is going to cover a certain level of care for rehab. And if not, just know, as I discussed already, there's lots of other options for you if you cannot be accepted to an inpatient rehab program.
Perfect. Thank you so much for joining us today. We're so happy that you also could join us for the love of you. And until next time, thank you.